Good afternoon, everybody, and welcome to this webinar on optimizing antenatal care during the COVID-19 pandemic. We are all very joyous when we have a mother expecting a baby, and the pandemic should be no reason for us not to be able to do our duty in fulfilling her needs. In this webinar, we hope to be able to tell you about the virus and modes of transmission, the effect of COVID-19 on the mother, the effect of the infection on the fetus, antenatal care for non-COVID pregnant women, and the care for the suspected or confirmed COVID-19 infection women as well. So the novel coronavirus disease was nicknamed as the 2019 COVID-19. And severe acute respiratory infection, acronymed SARI, caused by this SARS-CoV-2 virus, was first identified in Wuhan city in China. The outbreak of the pneumonia was of an unknown cause initially, and then this was detected in the bronchoalveolar lavage samples. Though it started first from the animal source, it was confirmed that it could spread from person to person. And even simple coughing, sneezing, close personal contact, touching one's nose, mouth, or eyes before washing one's hands adequately would be sufficient to spread this virus from person to person. Currently, it is unknown if this virus can spread through semen or sexual intercourse. What are the effects of COVID-19 on the mother? Some viral infections are worse in pregnant women due to physiologic changes in pregnancy or the relative immunosuppression in this time, but there is no such evidence for coronavirus infection. Pregnant women have so far not been found to be more susceptible to the consequences versus the general population, and maternal diseases have not been found to be aggravated by pregnancy unless they have associated comorbidities. How do we assess for these comorbidities? These could include hypertension, diabetes, asthma, HIV, heart disease, chronic liver, kidney, or lung disease, blood dyscrasias, and also any immunosuppressive situations. It's important really to take precautions against COVID-19 in all such cases and to report possible symptoms at the earliest to health providers. Now, looking at the clinical picture, if COVID-19, in these women as well, in the majority, there will only be a mild or moderate cold or flu-like symptoms, a cough, sore throat, or fever over 37.8 degrees C, that's 100.4 Fahrenheit. In a few, there could be severe infection, shortness of breath leading to SARI, pneumonia, marked hypoxia. Critically ill patients would present with tachypnea, where their respiratory rate is more than 30 per minute, hypoxia, where the saturation is falling to less than 93%, and the imaging showing more than 50% of lung involvement. Immunocompromised and elderly pregnant women are definitely a high-risk situation, and in these patients, fatigue, malaise, body ache, and/or nausea and diarrhea have also been reported. Now, what is the effect of COVID-19 infection on the fetus? There is no reported increased risk of miscarriage or early pregnancy loss. Preterm births have been reported, and it's unclear whether these are iatrogenic or spontaneous, because there haven't been so many pregnancies yet reported. But there is no evidence so far of intrauterine fetal infection, congenital malformations, effect on fetal growth, no vertical transmission or transmission through the genital fluids. Preparedness is the essence. Maternity healthcare providers need to prevent consequences of the infection on the mother, consequences of the infection to her newborn, spread of infection from the infected pregnant woman to other pregnant women, and spread of infection also to healthcare providers. So high quality care is really important before, during, and after childbirth. Antenatal, intranatal, newborn, postnatal, and not forgetting mental health to make it a complete picture. Very important aspects of antenatal care for the non-pregnant women include the antenatal contact and advice on diet, hygiene, attention to infection prevention and shielding, and travel and quarantine. And the antenatal advice for pregnant health workers is equally important. In antenatal contact, we would like to recommend at this time to reduce, postpone, and/or increase the interval between antenatal visits and routine scans. The duration of each antenatal visit should be shortened to the necessary. Visitors should be absolutely limited while in hospital, and the plans for the women who require frequent reviews need to be individualized. We must continue to provide necessary prenatal care and antenatal surveillance for high-risk cases. Do the basic 4. Minimum contact is 12, 20, 28, and 36 weeks, which is absolute minimum. Now, further, we can move into antenatal care with teleconferencing and video conferencing, which could be a replacement or which could be in addition, especially if maternal observation or tests are not required. So what can be done at this time? Virtual prenatal care visits, online communication with providers, consultation with specialists that includes the maternal fetal medicine, the genetic counselors, as the case may be, and mental health care, again to be remembered because really it's a highly stressful situation which patients were not prepared for. Advice for home monitoring wherever possible would be the blood pressure check, maternal weight check, but in all cases, the daily fetal movement count can be emphasized. Dietary advice is not changed because of this pandemic. There's no particular diet to treat or improve immune status or reduce their infection risk. And there have been concerns about consumption of meat, chicken, or eggs, but really there is no increased risk of acquiring coronavirus through these. So generic dietary advice, really high protein diet, vitamin and micronutrient supplementation, as you would recommend to a pregnant woman. Advice on hygiene is the most important. Attention to infection prevention depends upon doing the 5. Staying at home, hand hygiene, not just washing frequently, but washing properly and for a minute for sure. Avoiding touching the face. It is said that the mask not only helps to prevent infection, also keeps you from touching your own face. Social distancing and respiratory hygiene, coughing or sneezing into a bent elbow or a tissue. Advice on travel and quarantine. Of course, at this time, all travel is banned, but as the lockouts are taken off, avoid all non-essential overseas travel, and the criteria really remain the same for pregnant women and the general population. We talked earlier also about shielding. What is shielding? Shielding is the measure to protect clinically extremely vulnerable people who could be, for example, pregnant women with significant heart disease, both congenital and acquired, and immunocompromised women. Now, it's important to minimize all interaction between this extremely vulnerable group and others. They should stay at home at all times for at least 12 weeks. And within the home, they must minimize all non-essential contact with other members, keep a distance of not just 1 but maybe 2 meters where possible, access medical assistance remotely wherever possible, and family members also should take care to remain home and not bring in infections and not get into any unnecessary contact situations. Pregnant health workers, care workers are our priority as well. And we must advise those who can work from home to do so. and at any gestation they should be offered a choice whether to work in direct patient-facing roles or not. If they are less than 28 weeks gestation, the same advice of practicing social distancing, and they can choose to work in a patient-facing role with the necessary precautions. If they are more than 28 weeks gestation or they have underlying health conditions, they should avoid direct patient contact, and it is recommended that they should work from home. Antenatal care for pregnant women with suspected or confirmed COVID-19 infection. This is now a very special space we are coming into, where we have to think about the antenatal contact and the algorithm for managing these positive or suspect positive cases, whether they are symptomatic or symptomatic. Now, pregnant women with suspected, probable, or confirmed COVID-19, including women who may need to spend time in isolation, should have access to woman-centered, respectful, skilled care, including obstetric, fetal medicine, and neonatal care, as well as mental health and psychosocial support, with readiness to care for maternal and neonatal complications. This is the recommendation coming to us from WHO. So when they are with suspected COVID-19 infection, when should they contact? If they have mild symptoms, they do not need to panic, and they may just contact the maternity team to let them know of this problem. But if they have severe symptoms or there is an urgent problem related to the pregnancy, they must contact immediately. And this information has to be given out to every pregnant woman who will undoubtedly be concerned in this pandemic about how she is to go about it. How does she contact? The principles are that they must not come to the routine clinics, which they would be at risk of exposing other people. They must come directly to an initial assessment or triage area that is created in each facility, or a screening area where they are strongly positive, and they must bring the minimum number of people with them, use a private transport, not a public transport, and if an ambulance is required, they must tell the call handler that they have a current suspect status to make sure that they use the precautions and also take them directly where they go. What is the algorithm for pregnant women with suspected or confirmed COVID-19 infection? The first point of contact, as we mentioned, we must have an assessment area for triage and screening of these patients. If the patient has fever more than 38, cough, difficulty in breathing or shortness of breath, or GI symptoms, or there is a history of exposure, travel to an affected country within the previous 14 days, or close contact with a confirmed case of COVID-19, close contact having been defined as less than 1 meter for more than 15 minutes, living together, or direct contact with body fluids. We should give the woman a surgical face mask initially and maintain a minimum 1 meter distance from each other. Now, an infectious disease specialist will assess the case to assess the severity. Is she in an elevated risk category or is she in a moderate risk category? The obstetrician will assess to see, does she have any obstetric emergency? Is there a labor or delivery issue? And if the answer to these is no, then isolation at home for 14 days with clinical self-monitoring is sufficient. If symptoms persist, this patient needs to be tested for COVID as per the guidelines. But if the answer to these is yes, then she needs admission and she is to be managed according to the guidelines of admission, which means that here is a patient who is not in labor and she is COVID positive likely. So we have to institute infection prevention and control measures, immediately transfer her to an identified isolation room. The donning of appropriate PPE by the healthcare providers is absolutely important. And we have to test the pregnant woman with suspected infection This should be done urgently. We send the nasopharyngeal swab. This is to be collected according to the guidelines by the appropriate personnel, transported in the right way. And we must not delay her obstetric care in order to test. We should treat her as a confirmed COVID-19 until the test results are available. A multidisciplinary approach is required at all times: obstetric, neonatal, and intensive care specialists. If these confirmed cases are asymptomatic, we have to see they have no comorbidities and they have no obstetric emergency or labor, then home isolation, and we will check after 2 weeks about the baby's growth and Doppler. The antenatal contact routine appointments, growth scans, glucose tolerance test, regular antenatal care appointments are all delayed until after the recommended period of isolation, and no additional tests are required. If there are concerns about the well-being of themselves or their fetus during the self-isolation period, the patient is advised to contact maternity team and given the necessary numbers and make sure she knows how to get there. Additional care is required if they have any complications. They must be provided counseling and information about the potential risk of adverse pregnancy outcomes. If the patients are symptomatic, they are to be hospitalized based on the severity of symptoms and obstetric emergency or labor. And the place of admission needs to be determined. You have to assess the need for ICU admission using the criteria, the maternal early warning criteria, where the systolic blood pressure less than 90 or more than 160 millimeters mercury, diastolic BP more than 100, heart rate less than 50 or more than 120, respiratory rate less than 10 or more than 30 per minute, oxygen saturation in room air less than 94, oliguria, which means urine output is less than 35 ml per hour for more than 2 hours, maternal confusion, agitation, unresponsiveness, known patient with preeclampsia reporting a non-remitting headache or shortness of breath. Or we can use the quick sequential organ failure assessment tool, acronym SOFA, and if there are any 2 out of 3, that is a systolic BP less than 100, a respiratory rate more than 22, or an altered level of consciousness, if any of this is present, she goes to the ICU. If not, we continue with the monitoring. The severe failure criteria require the emergency cesarean delivery option to be considered if the patient is going into septic shock or acute organ failure. Maternal surveillance consists of taking their temperature, heart rate, BP, respiratory rate 3 to 4 times a day. The chest imaging can be done, high resolution CT scan or X-ray can be done if indicated with an abdominal shield and after informed consent. We should consider oxygen therapy to keep the oxygen saturation more than 95% and encourage oral hydration, limit IV fluids if there is a concern of cardiovascular instability. This is part of the recommendations which have come out from FOGSI, which has given the PR recently. Also, the antipyretic therapy for maternal comfort as well as limiting the fetus to the risk of high body temperature. We know that there is a risk always with any high fever. Screen for other viral infections or superimposed bacterial infections, and consider empirically IV or oral antibiotics, antimalarial, antiviral treatment, and consider thromboprophylaxis. For the fetal surveillance, we continue to monitor these symptomatic cases with the fetal heart rate and daily fetal movement count. Antenatal corticosteroids can be considered in women who are at risk of preterm birth from 24 to 34 weeks of gestation if there is no clinical evidence of maternal infection and mild COVID-19. It is estimated that the clinical benefits might outweigh the risks of potential harm to the mother. Now, as we care for these pregnant women with suspected or confirmed COVID-19, looking at the recovery from illness, There's little evidence of natural history of pregnancy after recovery because of the few number of cases so far. If they have recovered from infection in the first trimester, we should consider detailed mid-trimester anatomy ultrasound examination. If they have recovered in the latter half of pregnancy, we should consider a sonographic assessment of fetal growth 2 weeks after the assessment. So the take-home messages from this talk are that pregnant women should follow the same recommendations as non-pregnant persons for avoiding exposure to COVID-19 infection. Antenatal care through teleconferencing and video conferencing is the key to providing quality care during this pandemic. The triage based on symptom severity and obstetric emergencies is important, and a multidisciplinary approach to management of suspected or confirmed cases is the key and the need of the hour. A few of the guidelines which may be of interest to you, we have compiled them here. I hope you found this to be helpful, and we will have a panel discussion to take your questions. Thank you.
Good afternoon, everyone. Today, we will discuss the management of labor and delivery in women with suspected or confirmed COVID-19 infection. This is the second part of the webinar series discussing the management of pregnancy in the times of COVID-19 pandemic. In the first part, we discuss the antenatal management of pregnant women. In this part, we will discuss the facility preparedness, the infection prevention and control measures, the general considerations in labor, the triage, the care in labor, the clinical monitoring, the delayed cord clamping, and before we go on, I would like to reiterate that even during these times, all women have the right to have a safe and positive childbirth experience, whether or not they have a confirmed COVID-19 infection, as has been mentioned by World Health Organization. To begin with, as much as possible, these are the times of teleconferencing, the antenatal preparedness, and we should reach out to the antenatal women and tell them to contact their maternity teams in advance, use private transport, and also restrict the number of attendants with her as much as possible for their own safety and for the safety of the healthcare providers. Now we come to the part of preparedness of the healthcare facility. These are the times when every facility should be prepared to handle a suspect or a positive case. An inadvertent case can quarantine a whole lot of healthcare providers. A systematic approach to preparedness is the key to successful management of any COVID positive case. So, the components of preparedness would be building up a standard operating procedure, preparing the local infrastructure, train the personnel, procure personal protective equipment, and adopt the standard infection control practices. Regarding the first step, that is the standard operating procedures, various societies have given guidelines. Yet, it is important to adapt these to the individual facility, to chart out a path of the patient from the point of entry in the designated screening areas to the place of isolation to the time of exit. We have shown a sample here of the SOP that we developed for our own department. Next is the infrastructure. By infrastructure, it is not necessary that a separate facility that should be made available for this purpose. However, for safeguarding the other pregnant mothers and the healthcare providers in the facility, it is important to identify a small area for screening and triage in the facility. Ideally, it should have a negative pressure zone. It should be a negative pressure zone, and extra items should be removed. However, Even a small area should do. There should be a separate delivery room and OT for the suspect and confirmed COVID-19 patients, and the neonatal resuscitation corner should be 2 meters away from the delivery zone. Regarding the personnel, all the staff should be trained in the use of personal protective equipment. The staff entry into the isolation room should be minimized. The COVID response team should be trained for management of emergency scenarios, and regular mock drills should be conducted so that they can handle the emergency situations. WHO has given guidelines for rational use of personal protective equipments which should be followed at all times. For example, healthcare providers who come in direct care of the COVID-19 patients should be given medical masks, gowns, gloves, and even eye protection. However, staff in the screening area may not use such high level of personal protective equipment so that we are able to rationalize PPEs at all times. Now coming to the infection control practices. The training for the healthcare providers should be provided in correct disinfection and waste disposal practices for the positive and suspect areas. All pregnant women should be encouraged to inform the unit before they come. All women should be screened with a history of travel, occupation, contact, and cluster. All asymptomatic healthcare workers should be encouraged to wear surgical masks. Can we allow a birth companion? Ideally, in these times, it should be avoided. However, if it is deemed necessary, they should be screened by the standard policy, and if it is necessary and they are asymptomatic, this can be allowed preferably via a video, or if it is to be allowed, they should be allowed to remain in the same room and not be allowed to go and come back frequently. Let's talk about the more common questions that must be bothering us all. Does cesarean section benefit the mother or the baby? Currently, there is no evidence to favor one mode of delivery over the other. This should not be influenced unless the mother's respiratory condition demands urgent delivery. Counsel the woman, consider woman's preferences. Cesarean section should ideally be undertaken only when medically justified, dictated by the usual obstetric practice. However, the use of birthing pools should be avoided. What about a planned induction of a positive patient? An individual assessment regarding the urgency of planned induction of labor requires to be done. If the induction of labor cannot be safely delayed, the general advice for COVID-19 should be followed. Women should be admitted into an isolation room in which they should be ideally cared for the entire duration of hospital stay. What about the timing of delivery? It is not dictated by the presence of COVID-19 infection. Again, COVID-19 infection is not an indication to induce labor. If the infection has occurred in the early pregnancy, there should be no alteration in the timing of delivery. If, however, the infection has occurred in the third trimester, it is reasonable to postpone the delivery until the test is negative or the quarantine status is lifted. However, if the woman is critically ill, then in that case, delivery might be indicated to relieve the extra metabolic or pulmonary load. And in that situation, it might be we need to weigh the possible risks and benefit of the worsening systemic status with the surgery. So we need to individualize the clinical stability of the mother depending on the stability of the mother, period of gestation, and the fetal condition. So the next aspect is about the testing of the pregnant woman. Now, if we are planning a planned cesarean or a planned induction, should we test the woman for COVID-19? Now, this situation is going to arise for each and every one of us. If the patient is asymptomatic, should we test the mother? Now, it has been seen that even if we test, the test might be false negative in 30% of the cases, and it might be positive in 30% of the cases. So, it is very difficult in the current scenario to make a recommendation. So, as of today, it is difficult to, in asymptomatic mother, postpone or reschedule our inductions to wait for the report of a COVID-19 test. But in a symptomatic mother, should we continue induction or a cesarean? If a mother is already symptomatic and we want to postpone the surgery, we need to keep in mind that the patient might become more sick in the second week of illness. And in that situation, we need to weigh the risk of continuation versus termination. So we might want to discuss with our medicine colleagues and take the risk accordingly. Now we come to the most important part, which is the maternal fetal assessment in labor or triage. This part has been discussed in the antenatal management. Now, any pregnant woman should first be screened with history, symptoms, exposure, and if any of this is yes, so give the woman a surgical mask, maintain a minimum of 1 meter distance from each other, and assess. The assessment should be ideally by an infectious disease specialist and also an obstetrician. Does she have an elevated risk? Does she have any obstetric emergency? If the answer to both is no, can we do a home isolation? In that situation, she does a clinical self-monitoring, and if the symptoms persist, she goes for a testing as per the guidelines, which might change every day as they are happening currently. Now, if she has any obstetric emergency or a labor delivery issue, then we admit her, and we are subsequently discussing this aspect in the present webinar. Now, she has been admitted because she is suspected to be in labor or some other obstetric emergency. Now, institute all the infection prevention control measures, immediately transfer her to an isolation room, pre-designated isolation room, don the appropriate PPE, and send her nasopharyngeal swab for testing. And then the maternal fetal assessment is done. The maternal assessment would include a temperature, pulse rate, blood pressure, respiratory rate, oxygen saturation, and confirm the onset of labor by upper abdominal and pervaginal examination as appropriate. The fetal assessment in this case would include continuous fetal heart rate monitoring. Are there concerns regarding mother or the baby? Is the patient in labor? If not, is it a false labor? Do we think that the patient can go home? Then in that case, give her the usual discharge advice that you would give. Look out for leaking PV, bleeding PV, pain, decreased fetal movements, and send the patient home. At the same time, advise her on the symptoms of deterioration of COVID-19. If, however, the patient is in labor, keep the patient in the same isolation room and continue monitoring for labor, which would be according to our standard labor monitoring protocol, except that you would also monitor her oxygen saturation, which should be more than 94%, and watch out for symptoms of difficulty or shortness of breath. What we also need to understand in this case is that COVID-19 in majority of mothers is only a mild to moderate cold or flu. However, in certain cases, it can become severe, and this is what we need to watch out for. The patient can develop tachypnea, hypoxia, and this needs to be monitored by maternal early warning score or a quick sequential organ failure assessment tool. And if any of these criteria become positive, we need to watch out for these, and she might even require an ICU admission. And these are the situations in which even an emergency cesarean section delivery to relieve the maternal stress might be required. So continuous monitoring of mother along with a continuous fetal monitoring is the key to a good maternal fetal outcome in labor. If we talk about the other aspects of intrapartum management, it is not principally altered. However, person to person contact should be kept to a minimum. Time in labor should also be limited. Prolonged difficult labors should be avoided. As the virus is not detected in vaginal secretions, amniotomy can be done. A quick word about preterm labor. Tocolysis is contraindicated. A study has shown that in 41 pregnant deliveries in women with this infection, the risk of preterm labor was as high as 35%. However, tocolysis should be avoided, but steroids for lung maturity can be given. Is labor analgesia can labor analgesia be given? There is no evidence to say that labor analgesia is contraindicated. For the purpose of cesarean sections, regional anesthesia is preferred because general anesthesia is considered to be a aerosol generating procedure. What about Entonox? There is a bit of controversy regarding Entonox because RCOG recommends it. However, Society of Obstetric Anesthesia and Perinatology considers it to be it is not recommending it at present time. Regarding delayed cord clamping breastfeeding, delayed cord clamping is still recommended as virus is not considered to be transmitted through blood. Regarding skin to skin contact, after counseling for risks and benefit, it is an individual choice and it can be done if the baby is doing well. As regards breastfeeding, a woman with COVID-19 should be supported to breastfeed safely and hold her newborn baby to the skin and share a room with her baby. It is felt so because virus has not been seen to be secreted in breast milk and hence WHO supports breastfeeding at the present time. Women with COVID-19 can breastfeed if they wish to do so, and they should practice respiratory hygiene and wear a mask. If a woman with COVID-19 is too unwell to breastfeed, she can be supported to safely provide her baby with breast milk in other ways, including by expressing breast milk. To summarize, all health facilities should have preparedness to handle suspect or confirmed women of COVID-19. All women, despite the pandemic, have a right to safe and positive childbirth experience. Principles of labor delivery management remain the same, except that facility for isolation should be there for the safety of pregnant women and healthcare providers. Breastfeeding should be encouraged in eligible neonates. These are some of the guidelines which can provide important practice tips for everybody. We hope that this webinar will be useful for your clinical practice. There will be a panel of experts for discussion after this webinar, and we hope that you will put in your questions. Stay home, stay safe. Thank you. Good.
Thank you for attending the webinar. We have an expert panel from AIIMS and we will take your questions and help you clarify your doubts. The first question was asked to us that should a pregnant patient be seen at 12, 20, 28, 32 weeks? By this, are we increasing the exposure to hospital environment, and do we believe there is no community spread? How many routine tests and routine visits should be there for a patient?
For low risk patients, we can have at least minimum of 4 visits at 12, 20, 28 and 36 weeks. As of now, there are local spreads, community spread is not there. So we can call them as per the physician, the treating obstetrician. If they are high-risk patients, then it depends on the obstetrician when they have to be called, because maybe they will require frequent visits.
Thank you, ma'am. Ma'am, next question I would like to ask that do we still continue first trimester aneuploidy screening and second two, or just a congenital scan? Or there was one more question that was raised that my patient is missing her anomaly scan at 20 weeks. So I'm worried. Any other alternative?
For anomaly scan, I mean, there's no alternative. It will have to be done. So maybe wait for a week or so and see. Once the things are better, you can go. Or you talk to your obstetrician. If it is really essential, then maybe you can fix an appointment from the ultrasound lab and go there in your own vehicle. And when you have an appointment, you don't have to wait there for very long. And as hygiene practices have been explained, you can use a mask. Don't touch any surfaces. Wash your hands when you come back.
So you practice all these hygienes and then can get it done. But avoid as much as possible going out.
Thank you, ma'am. Next question was asked to us, how vulnerable are adolescent mothers since a large number of them are anemic, and how to manage a teenage pregnancy in these cases?
Adolescent pregnancies as such are, if we are talking specifically about COVID-19, then they are at the same risk as the general population adolescent is. And since the patient is pregnant, then we should again follow the same precautions, like should not go out much and should remain in the house, follow all the cleanliness advice, frequently wash your hands, and avoid crowded places. And as far as anemia with adolescent, most of our adolescent girls in our country, we know they are anemic. So if you are pregnant, then beyond your after your 3 months of pregnancy, you can start your routine antenatal iron prophylaxis, which can be safely taken even during this pandemic era. And as ma'am has already discussed, that you can go for your routine antenatal checkups. One thing is important, that if you are going for your routine antenatal checkup, where we have now decreased the antenatal visits to 4, discuss about that period of gestation and also make a plan for the further pregnancy, so that in case you are not able to come back again because of some reason, you have an idea what to do for your next planned antenatal visit.
Thank you, ma'am. Continuing on this question, which drugs can be prescribed and which can't be prescribed by telecom?
As far as the pregnancy is concerned, we are usually giving folic acid for normal or low risk pregnancies. We are giving most commonly prescribed drugs are iron, calcium, and folic acid, which can safely be taken and can be prescribed by telecommunication. And apart from these drugs, if the patient is having any other requirement because of comorbidities, hypertension, diabetes, or any other medical illness, then the patient should consult the doctor, consult her physician, and then accordingly the same physician can modify the drugs, because starting a new drug should require an examination or some investigation.
Thank you, ma'am. The next question was asked that my wife has got 2 injections of tetanus and 1 of influenza. Now she's 27 weeks. Now there is Tdap. Should we give or should we not give?
So as she has already received 2 injections of TT, so there is as such no requirement. But if you want your wife to have Tdap, then it can be given up to 28 weeks.
Okay. Next question was asked, can antenatal healthcare workers take HCQ prophylaxis?
As of now, there is no good evidence that taking prophylaxis is helpful. So the government guidelines are that people, frontline workers who are actually working with COVID positive patients or who have had an exposure can take HCQ. But again, not as a routine for everyone. And you have to consult your physician before taking the drug, because it can have some serious side effects also.
Thank you, ma'am. If a pregnant lady is in early pregnancy, UPT positive, complains of backache and morning sickness, can be prescribed treatment without examination, without ultrasound for confirmation of location of pregnancy?
If the patient is complaining of mild backache that is relieved on rest and just a nausea of pregnancy, then usually she does not require any medication per se. Rest itself will be okay, and slight modification in the meal plans will be okay. But if she is complaining of giddiness, if she is complaining of headache or severe abdominal pain or backache or colicky type of a pain, then I think she should consult her obstetrician and go and show.
Okay. Another question we had was, if a female becomes pregnant and is anxious of her pregnancy and wants termination, how should we counsel? We have a representative from the WHO.
Thank you for that question. I think that the counselling related to medical termination of pregnancy remains as per the Government of India guidelines. If the woman requires a pregnancy, COVID itself is not a reason for termination. I think that the counselling should be done properly, and the decision should be made based on information and requirement of the couple and as per the suggestion and guidance of the obstetrician.
So this answers the question that do we give medical MTP or surgical also?
Sure. The guidelines remain the same. Government of India guidelines for medical termination of pregnancy are clear. Up to 9 weeks, you can give medical abortion drugs. However, it may be suitable as per the advice of the obstetrician to go for surgical because it's a one-time procedure. Again, the guidelines remain the same that are currently under the law.
Thank you. Coming to the labor part of it, there was a question that is there any risk of transmission to the fetus?
Till now, there are no studies for this, but there are no study for this. There is any transmission to the fetus from amniotic fluid, from placental transmission, or from vaginal discharge, because this virus is not found in vaginal secretions and in amniotic fluid. So there is no chances of transmission of. There is no chances of vertical transmission, but in fetus.
Thank you, ma'am. Most patients hide their history, and so do we need thermal detection tests in the trial during?
Yes, if it is there, it's a good idea. And you can always have a checklist also of what questions you want to ask. You can do thermal imaging, you can even look at the saturation and history based.
It's a good idea to have thermal detectors, but there is no shortcut to not taking history. So, history of travel, occupation, contact, and cluster. So, that should be a complete checklist.
And symptoms.
What about birth companion in labor?
So, as we discussed during the webinar, ideally it should be avoided, but if it is deemed necessary, the birth companion should be asymptomatic. It is like in countries like Italy and US, they are saying that if possible, allow a birth companion through a video call. Even if that is not possible, then if you are allowing a birth companion, let that companion stay in the same room as the patient throughout the duration of labor. Don't let him or her go in and out of the room.
Ma'am, next question was, could complete PPE be used in healthcare professionals for performing cesareans or deliveries or other procedures for non-suspects also in condition of pandemic when there may be asymptomatic carriers?
For suspect patients, there is no guidelines for using PPE, but we should cover our head by cap, cover mouth by nose and mouth by mask, and we can wear one disposable gown or non-permeable gown and with gloved hand.
One has to be rational about using PPEs also, because you may then run like short of things and you won't have anything. So it's very important to rationalize, and what kind of PPE, when to wear also should be clear for the health professionals.
Ma'am, how to differentiate breathlessness in a pre-eclamptic patient and COVID positive patient?
A COVID positive patient will have breathlessness, but also have other symptoms like fever, cough. She may have hemoptysis, and there may be a history of contact, or she's coming from a hotspot cluster where there is patient like similar cases are there. Whereas a patient with preeclampsia would have high blood pressure. She may have swelling over the body. She may also have breathlessness if she is going into failure or something. So, based on this, we will be able to differentiate. Yes.
Thank you. Ma'am, what are the effects of labor on COVID-infected pregnant women?
If a COVID-infected patient is symptomatic, then there might be problem during the first stage of labor, second stage of labor. More problem in second stage of labor because that is exhaustive nature of labor. So in second stage of labor, we can take all precaution. We should give oxygen by mouth, and we should cover her mouth and propped up in position, and we should cut short the second stage of labor if she is if labor is prolonged. So these precautions we can take during if she is we are allowing her to going in normal delivery.
Ma'am, is there any indication for cesarean section in COVID positive patients, or electively we should perform cesarean sections?
So as we discussed, it's not an indication for cesarean section. We should do it for obstetric intervention.
Maternal condition.
It all depends if the patient is having respiratory distress, she is in SARI or she is in severe illness, and we know that because of her illness she is not able to cope up with the vaginal delivery, then cesarean section can be done. But otherwise, in mild cases or positive asymptomatic cases, we should go via obstetrician.
Not favoring one mode over the other. Ma'am, is there any specific complication with regards to management of neonates? Do we continue delayed cord clamping or do we do early cord clamping?
Right now, there are no guidelines regarding this early cord clamping.
So we are practicing
delayed
cord clamping
cord
because it is not a blood-borne virus. Ma'am, is there any specific separate hospital for all these COVID-19 pregnant patients?
So this is a question that needs to be addressed because the Priya from WHO also I would like to invite her to say a few words about it.
So, Government of India is currently in the process of identifying designated hospitals that can serve as COVID-specific hospitals. But even within that, there is a need to make sure that maternity wards are still functional. Women that are either suspected COVID cases or positive, or even unsuspected cases or patients that we know have no history are given the care that they need. Respectful maternity care remains the cornerstone of our health system as an essential service, and that must be given. So although there are COVID facilities that are being formed right now, we are in the process. WHO is supporting Government of India, and we are also looking forward to working with AIIMS to come up with protocols and guidelines that can be issued to set up isolation wards or maternity wards that are there within these COVID facilities and other district hospitals as well. So services must continue.
So, as far as possible, if everybody is trying to make COVID designated facilities, but what we need to understand that maternal and health care has to be built up in each and every facility that is now presently catering to maternal child health. So each and every facility has to come up with its own area designated for COVID patients. So each and every one of us has to prepare for their own for caring for a COVID positive mother and child.
Thank you, ma'am. I hope we answered all your questions, and if there are any doubts, please contact us.